All right, welcome everybody. This is the National Care Coordination Academy. We're really excited to have you all today. It's been a little bit since we've connected. I'm going to start off with welcoming Meg, our project officer, to welcome you all.
Hello, and thank you all for joining us today. My name is Meg Camo, and I'm a Senior Project Director with the Center for Innovation in Social Work and Health at Boston University, and the Principal Investigator for the Collaborative Improvement and Innovation Network to Advance Care for Children with Medical Complexity, which is a project sponsored by HRSA, the Maternal and Child Health Bureau, and we are grateful and pleased and honored to be partners with Boston Children's Hospital in sponsoring the Care Coordination Academy and its attendant sustainability affinity group. So welcome today. I want to start just by quickly thanking not only you all for being with us today, but the Care Coordination Academy leadership and staff for the agenda that they've put together. It's exciting, it's interactive. We think it's going to be a lot of fun. And I want to thank them for that work. So I'm going to turn the floor back over now to Heather, who's going to lead us through some housekeeping details, and then we're going to get into our agenda. So thank you again all for being here.
Thank you, Meg. All right, so just some housekeeping that we go over each time. So just to let you know, this meeting is going to be recorded. Your breakout groups where you'll be with your team only will not be recorded. Please don't use speakerphone and please don't put us on hold if possible. I do love a good hold music, but it can be distracting. So please do not put us on hold. I have all participants muted when you first join. You are able to unmute when we get to the discussion portion. You'll be able to unmute and speak. But if you have any comments or questions throughout the event, please go ahead and put them in the chat. And the chat will be closely moderated and we will bring questions and comments up when available. Please take some time to rename yourself to include your state team name first. For example, right below here, you'll see Colorado and then Sally Smith. On my next slide, I'll show you how you can rename yourself. And if you are joining by computer and phone, if you could please link your phone with your computer. This slide just shows you how to rename yourself. So if you find yourself in the participant list, you then are able to right click on your name and you can go ahead and rename yourself to include your state abbreviation first. This will help when we get to the breakout groups where you are able to self-select breakout groups if you are running the most up-to-date version of Zoom. If you're not, we will assign you directly to your state team, but it's best if you're already labeled with your state team so we know where to put you. We are offering continuing education credits to RNs, NPs, MDs, PAs, and social workers. To be able to obtain your certificate, you must do the following. You'll put your information on the attendance Google Doc. That will be shared in the chat by Erica in just a few moments, and we'll share it a couple times today. I will also then email it out later for anyone that wasn't able to sign it during the meeting. We'll ask that you complete today's evaluation, which will be sent out at the end. Once you do both of those, the attendance sheet and our evaluation, we will send your information over to the Boston Children's CME department, and they will then send you an additional email that will give you instructions for how to obtain your certificate. Receiving the email from the Boston Children's CME department can take up to 2 to 3 weeks, so please be patient. If anyone from your team was not able to join today, but they would like to watch the recording, our recorded lectures are able to offer continuing education credits for up to 6 weeks past the live date. So today's lecture will be uploaded to Open Pediatrics by tomorrow, and participants will have up to 6 weeks to watch it and do the same process, complete the evaluation to obtain credit. If you have any questions or concerns about this, feel free to email me. So today's agenda, as Meg said, we have a packed agenda and hopefully it's going to be lots of fun and interactive. We're starting off with our welcome remarks. I'll introduce Rich in just a few moments to go over some items. I'm going to go through the team progress survey results. Thank you all so much for completing that. We will then have Jeff Schiff and Foster Justin do some role playing, and that's going to be a really fun session. We'll take a quick break from 1:20 to 1:30. When we return, we'll go to team breakout groups. This is a different feature. When we come back from team breakout groups, we're going to do team report outs. So we would like you to be prepared to share about 3 to 5 minutes of what you discussed in your breakout groups. And I'll share a little bit later the breakout group instructions. And we'll take time. We'll try to get to each team if possible. And then at the end, we'll do our closing remarks. Our learning objectives today. So after the session, participants will be able to articulate how they will present their work in the CC Academy and data to key stakeholders. They'll be able to develop a plan to prepare their work product for sustainability. They'll identify their target audience to demonstrate their work and identify the goal of their presentation, for example, funding sustainability. I'm going to kick this over to Rich.
Thank you, Heather. And I want to acknowledge the amount of work that's gone into this session by Heather Pamela, Erica Norkis, who's the coordinator of the Academy, our colleagues at BU, and then working with the faculty and guest faculty. So we're going to keep our pediatric mindset and think about a developmental trajectory. Today is for us is a major milestone. In the first year of the Academy, or in the last, say, 6 to 9 months, we were talking about concepts and principles and frameworks. We are making a conscious decision starting today to build off the wonderful chemistry and synergy that grew out of our March 10th meeting, where you might remember we had a panel with Dr. Michael Warren from the HRSA MCHB, Ellen Marie Whalen for the Centers for Care and Medicaid Services. And we talked about how can we get to sustainability. So beginning today, we are going to unite the sustainability group component of the Academy with the overall Academy itself, focusing on sustainability. We're adding a new feature. So in between these all team Academy sessions will be office hours facilitated by Academy faculty and as necessary guest faculty, where teams will be able to receive specific in-time technical assistance, enabling them to get to sustainability. Next. And so I'll remind you of the components, again, hearkening back to March 10th and some of the concepts that you have all seen that Heather is going to be discussing the survey that we sent out to you. To get to sustainability, what are the components of that model of care? What is the funding source and how do you maintain and sustain it? And what are we aiming for? What are the outcomes that we're actually measuring? So for the combination of the Sustainability Affinity Group with the Academy, these 3 domains are going to be of critical importance going forward.
Thank you, Rich. Okay, so I'm just going to briefly go over the team progress survey results. Thank you all so much for completing this. It's super important that we get these results so we can try to continue to make content that fits your needs. So I just wanted to show you first, there's lots of progress, so that calling this a team progress survey works perfectly. The current tools that are being implemented, if you look over to the first graph on the left, so the most popular one we have right now is the PICS, the Pediatric Integrated Care Survey. About 36% of teams have implemented use of the PICS. We then have the CCMT, the Care Coordination Measurement Tool. 21% of teams have implemented use of CCMT. We then have the FESAT, the Family Engagement and Systems Assessment Tool, a wonderful tool to use to make sure that you're always encouraging and establishing family partnerships. We have 29% of you that have completed it and actively have implemented an action plan to improve family partnerships. We have 7% have completed and implemented the high quality handoff tool. And then another 7% have implemented use of the action grid. So excellent job with implementing the tools. Next, I wanted to talk about how many people have implemented screening for social determinants of health. This one was really great. We have 67% of our teams that have implemented screening for social determinants of health. 33% in this group, it was a little bit split where some teams are in the process of implementing a tool. Some are still creating the tool, and then some are still figuring out sort of how they're going to move this forward in their practice. Then we have teams that have established family partnerships. This was awesome. Almost all of you, 89% said that you have established family partnerships. And this includes having a parent or caregiver representative on your family council group, or you're connecting with families routinely, you're involving them in your practices and your changes that you're doing, and you're making sure that they feel like a complete partner. Then we have our measures that are being tested. So as discussed, CCMT, we have PICS, the FESAT. A lot of you are using the Medicaid core set, the USMCHB Title V National Performance Measures, the National Performance Measure 11, and the NASHB standards for children and youth with special healthcare needs. So a lot of great progress is being done, and we look forward to continuing to see you guys continue to grow. So other things that we asked you in the survey is one of the last couple of questions, we wanted to directly ask you what you needed for technical assistance with a focus on sustainability. And as Rich showed you, the three-leg stool of sustainability is elements of the care model, measurement, and funding sustainability. And we wanted to ask you, what do you need from us to be able to continue to move forward in sustaining your care coordination activities? So the two most common themes that came out of the survey was, the first one is, a lot of people are asking, how do you analyze data meaningfully from CCMT and PICS? So it sounded like you figured out how to implement it and you're actively doing it, but now you're collecting this data and you're wondering, how do you go ahead and analyze this? And how are you going to present it so it will be helpful to continue to sustain your activities? So to be able to address this first item of how to analyze the data, we will be holding an open office hours in June, where Jessica Bellevue from the National Center of Care Coordination Technical Assistance will lead that event. We'll do about a half hour of some didactic work where she'll go over analyzing the data, and then we're going to leave it open to questions and teams to work together to how to best collect and analyze your data. So I will send more information about this soon, but that's how we'll address that item. The next one is what we're going to get into today. So a lot of you asked, great, you have all of your data, you have your tools, you're getting everything together, but now how do you put all of your work together meaningfully for a presentation to key stakeholders, whether that's for internal presentation, external, if you want to go directly to Medicaid, how do you put all this together so that it's organized and it can assist you with continuing to sustain your program? So today we're going to start this discussion. I will head things off to Jeff and Rich in just a few moments, but we'll just start the discussion now, and then we're going to continue to dive deeper into this topic going forward. So Rich, I will send it back to you to introduce Jeff and Foster.
Yeah, thank you, Heather. I am absolutely privileged to introduce Dr. Foster Gueston. I've had actually the honor of learning from him. We were at the National Quality Forum for several years together. You're going to enjoy this man's insight. I'm going to save for the discussion with Jeff why we selected Foster to play this role today. Let me tell you a little bit about my friend and colleague. Most recently, the Chief Medical Advisor for Quality and Healthcare Delivery at the Greater New York Hospital Association, where he was responsible for clinical direction of member initiatives and quality improvement, patient safety, and innovations in care. Prior to that, he held leadership positions within the New York State Department of Health. The last is the Chief Medical Officer for the Office of Quality and Patient Safety, which actually is an office that he helped to co-create. He's been the clinical leader at the New York State Department of Health, responsible for the development of quality measurement and improvement programs within the Medicaid program and with health insurance plans. He has assembled and been part of an extraordinary team that contributed to New York becoming really a national leader in public reporting of health system performance. The team developed innovations in the application of quality incentives, made measurable reductions in healthcare quality disparity between low-income and commercially insured populations. He also led New York's efforts to make timely evidence-based care for patients with sepsis a priority for all hospitals through strategic use of regulation, innovations in the measurement of clinical process and outcomes, and the accountability of public reporting. So in many senses, in fact, Foster is exactly who we need to help us as we move forward with the National Care Coordination Academy aiming for sustainability. So with that, I'm going to hand it over to Jeff. Jeff, you and Foster can take it from here.
Go off mute. Hi, everybody. Welcome to spring in America, and I hope you're all having a great time and it's sunny wherever you are. We are going to talk about, as I think Heather alluded to, talk about how and what we present to policymakers. And I think that one of the, as Rich said earlier, and I really want to emphasize this, we've talked about this theoretically, and we spent some time after we got the survey back thinking about what are the tools that that all of you would really benefit from, or that we could use to move this along. And so we talked about doing a one pager, or if you put it on both sides, a two pager, something to communicate with. And we want to kind of spend some time both talking about what that is, and then who it's for and what content it is. And hopefully, if you're willing to do this with us, and I think it'll be really beneficial for you to actually make these for your own programs. So I'm going to go to the next slide, Heather. I want to remind you of our travel log, and mostly because well, the little helicopter has been flying around Mars, but with a little piece of the Wright brothers plane on it, I guess I've heard. But I want to remind you that perseverance is a theme that we should all have, and we all must have if we've made it this far on the journey of working on care coordination for kids with special health care needs. I won't read the quote, but if you're new, it's a great quote, and you'll see it in a little bit. Next slide. Well, as we've been talking about these one or two pagers, and it's been the theme of Mother's Day, we decided we'd use that as a metaphor. And this is Heather's son, who we continue to track, and we're happy to track along with everybody else. But you know, we use this metaphor of a Mother's Day card because there are some things you write on a Mother's Day card, you know, that you know, what your mother does for you, why you appreciate them, you know, and that you care a great deal about them. And so there's a model here. This is a grandmother card, but so and Thomas Charles is young, so he hasn't put all those things on yet, but we're counting on him next year to fulfill a whole Mother's Day card, and we'll be watching. So anyhow, so with sustainability and with these one or two pagers, the selling can be it can be hard, but because you know what you do and you're really enmeshed in it, but you need to back up and remind the people who you want to care about you and what you do, what you're doing. So next slide. There's one distinction. The biggest distinction we have in the Mother's Day card between what Thomas Charles and this is the key element from this book by P.D. Eastman, which I read to my children and they know by heart. And it's a bird who falls out of the nest and says, "Are you my mother?" So I think that that's one of the distinctions. And there's also obviously distinctions in what goes into the content of a one or two pager. But I wanted to celebrate the fact that we're going to first ask, "Are you my mother?" Like, who do you have to present this to? Who do you need to get on board? And then what are you? And then what do you want to say? So I recommend the book if you haven't read it. Probably some of you know it by heart, like I did. So anyway, go ahead. Next slide. So anyway, Foster and I are going to do something here that hopefully will be fun. Foster, don't pick on me too badly. But I think we're going to go, we wanted to play out what happens after you have a one or two pager. And after you decide you're going to go talk to somebody, in this case, Foster's going to play a role that he knows well, being the Medicaid medical director. And I'm going to play a role of one of the team members on a care coordination group. And I'm going to present to Foster our two pager and see if I can engage him to go forward from where he's at. So anyway, With that, Dr. Gessner, are you ready for our not ready for primetime player thing?
Totally ready. Pleasure to be here.
Thank you.
Hi, everyone.
I'm going to stop sharing my screen just while you guys, so that everyone can hear you and watch you more accessible, and then I'll reshare when we get back to the presentation.
All righty. I think that's a good thing.
There you go.
Hi, everybody. Anyway, Dr. Gessen, thanks for meeting with those of us from the New Alaska Medical Clinics today to talk about our care coordination work. How are you?
I'm well. It's good to thank you for coming in. I look forward to our conversation.
So I know we sent you a little bit of a letter to ask for this meeting, and we really wanted to see if we could spend a little bit of time explaining what we do and see if we can form a partnership with you to figure out how we can move forward with the Medicaid program. Did you get a chance to look at what we sent you?
I did. I looked at it very briefly on my way in here. You know, I just got it. Somebody just handed it to me right before the meeting, so I didn't get a chance to spend a lot of time on it. So, but it looks interesting. A lot of questions, but why don't you start? I'm all ears.
Okay, thanks. And today I don't have anybody with me, but in other times I would have brought folks if we would have had a better time with scheduling. Well, I think I really want to talk to you because, as you know, children with special healthcare needs and children with medical complexity are really not well served by the system. And we've been at this for a while, trying to figure out how to help these kids. We know that from the work that we've done and some survey work that families are pretty stressed about how they fall through the cracks and then they end up in the ER and in the hospital. There are costs to families and then real dollar costs. So we started trying to figure out how to change that. We got a grant from a private foundation, and we started to identify kids and then to try to provide services in our 5 clinics to families of kids who were complex. So what we did is we tried to identify kids, and we know that in the past kids have been identified through a variety of different ways, sometimes in a more haphazard way, but we tried to identify kids through an algorithm that's based on their diagnoses and their ability to do actually activities, so their limitations on their functional status. And those are the kids we started to prioritize through this grant from the Michael Metal Smith Foundation. And we actually wanted to both screen kids for medical risk and then screen kids through for social risk and then prioritize those kids. What we did then, and I think that you know that this has been a challenge for to identify these kids successfully in these groups. I know that Medicaid has done some work on care coordination or case management as well. Is that right?
Yes, we have. So I'm curious about your screening because I mean, don't you screen normally? I mean, isn't screening kids and families for risk sort of part of regular primary care? What's special about that? And the screening that we often do is based on, as you may know, or you might imagine, based on high cost or frequent hospitalizations. Is that what you're talking about doing? Is looking
Right.
at kids that are hospitalized or
Right.
or have utilized a lot of services, or something different?
Right. So thanks for asking that. We did 2 things I want to point out. One is we started to screen all the kids in our practice for medical risk factors, basically through a diagnosis algorithm that we use that's been nationally recognized. But we also wanted to try to do something. I think the challenge that I think you probably know is that screening identifies through the claims system, which I think is what you're talking about, identifies kids who've already had problems. And we're trying to figure out where the kids are who are going to have the biggest risk. So we identified diagnoses. We asked some questions about functional status, like what kids could do. And then the other thing I think we tried to add to it now, which is really important, is we tried to add some of the social risk factors, because I think we've read some stuff that kids who are medically complex who also have social risk factors end up in the system more frequently. But
So your
we took-
I'm sorry. So your risk tool is really tries to predict the future risks versus just looking backwards. Is that, because that would be very important and very nice, but we know that the tools predicting the future are often kind of challenging. It's a challenge to be able to do that.
Well, we're not, I guess what I would say is our tool is more based on what the clinical needs are of the families, and we could use some help figuring out whether this is predictive of future use. And I think that's one of the challenges we have is we're not researchers, we're just trying to serve these families. And I think what we realized, for example, in one of our clinics in a pretty urban part of, or not urban, we're kind of up north, but in one of our sort of the regional hubs, we really found that we had a mom who, you know, had an unstable family situation and a kid who had complex needs, and we were hospitalizing that kid, you know, every 2 months, basically whenever the situation got bad. And we found that, you know, that's the kind of kid we were looking for to screen out and to find out if we could put this combination of social service support with our medical support and make a difference for them. So we kind of, what we really found out is that some of our kids, when we start to find them having some of these social risk factors, as well as some of their medical needs, we really realized that those are the kids that were taking up all the bandwidth for the primary care docs. Now that we had the coordinators from the grant, those are the people who needed the help the most. And we started to sort of prioritize them in real time ahead of some of their things. And we realized that if we could reach out and they could know they could contact us, we were stopping some of those hospitalizations. We don't have the data, which is part of the problem that we always have with some of these folks, but we have some data, I want to tell you.
So I'm sorry, the grant enabled you hired social workers?
We hired a combination. We actually were able to, in our 5 clinics, hire 2 full-time staff. One was a social worker and one was a nurse. So kind of the medical side and the social service side together. Mm-hmm. And so from the screening, we were able to get those 345 kids sort of into this pool of care coordination, and it worked. And I guess what I'd say is it worked for the following reasons. One is we identified the kids, and then what we didn't get to is because of some of the work that was done to identify these kids, to proactively go after and support them, we were able to what we saw is a year-over-year decrease in hospitalization by 20%. And when we looked at sort of unexpected hospitalizations for things that weren't planned, it went down by even more, by 43%.
Sorry, what went down? What went down by 43%? I get the hospitalizations, but
no, I said all hospitalizations went down by 20%, and we looked at hospitalizations that weren't planned, like hospitalizations for elective surgeries, whatever. Sure. It went down even more. So we don't have all the costs because we're just the primary care providers, but we're estimating that we saved $1,800 per child on these 345 kids. So, and that's just the savings in hospitalization. We're not talking about the, increased employment for the families or better school attendance and sort of decreased stress as well. The other thing I want to say that my family partners would say if they were here is that families and the teens really felt like they had some pressure taken off of them by having a partnership that worked. So I thought that was really important, and we don't get to that very often, but I think that stress is really important for the families that we serve. Um, so, so I know our time is limited today, but I wanted to just see if this resonates with you and ask you, we're here obviously because we want to get Medicaid to be a partner in this, and we know that that Medicaid's got a pretty full plate. But what are the things that resonate, and what else should we be thinking about to go to you or to go to your Medicaid director to sort of ask for some sort of support for this?
Well, first of all, thanks and congratulations on your success. I think it sounds like a really interesting program that that has a lot of resonance for us. We are always looking for programs that actually work to both improve quality of care and reduce costs. And as in our experience, those are not always as easy to come by as you might imagine. So particularly if you get rigorous with the data. So I think that the general theme of what you're trying to do resonates for us in terms of trying to identify individuals in our program that are most vulnerable, that I think, to use your words, fall between the cracks. And those cracks have implications for their lives and their health and for our costs as an insurer to taxpayers. So we're very interested in programs that have a track record, which it sounds like yours does, although there's some pieces of information that maybe we could work together to try to fill in some of those holes. I want to make sure, so I want to, and I'd like to explore this issue of support with you. I just want to make sure that I understand what it is that your group has done. You mentioned that there's a team, and the team includes clinicians that were in place prior to this grant, but you brought on a social worker and a nurse that work as part of that team that do, it sounds like, screen families and kids for their risks, both medical and social risks. But I don't completely understand what happens next. So what's the it that, I understand what social workers and nurses do, and I understand from what you said that you saw a reduction in hospitalizations, which is very interesting. I want to track back to that maybe when we talk about support and how we might be able to support that. But what's the intervention that the social workers and nurses did that you think made a big difference, both in terms of reducing hospitalizations as well as improving the decreasing stress on families?
Thanks. That's a great question. So what we did is we built a sort of a care coordination, care integration program where somebody who screened in would then be further evaluated in a much more thorough sort of evaluation with both the nurse and the social worker, sort of as needed. 345 people is a lot of kids for just two individuals. So we sort of developed this tiered evaluation that went from screening to intake to more of an integrated product. What we did is we really created this team structure. So the nurse, Jeremy, and the social worker, Betsy, would meet with they would go over the families that they screened that week, which would be about 15 families at the onset of this, to 25 families and kids. They would go through them, and then they would set up, we would dedicate some time, and we dedicated some time for team conferences in our system, so that of the 5 sites and the 30 primary care providers, about 2/3 were pediatricians. We would, depending on who was the primary care provider, we would roll in that doc's team, the social worker and the nurse into this thing, and they would create a care plan. They would then meet with the family. Some part of that group would meet with the family and create a plan and prioritize them, put them in our registry, and give them access, unique and better access to our system. And then I think the most important thing, which is maybe what you're getting at, is a plan is not a plan unless it gets worked. So the team would work the plan. And I think that that's where I think we made a difference that we haven't seen through some of the organizations that say, oh, we have a plan, we can check that box and move it along. These plans will get worked on a regular basis. And most importantly, I think of all that is when somebody fell through the cracks and would get an unnecessary hospitalization, we would do a review of why our plan failed. So, because we looked at unnecessary hospitalizations as one of our markers for failure. We also had another marker for failure I just want to bring up because I think it's really important. We gave the families the opportunity to evaluate on a relatively regular basis. So we gave them a tool where they could actually say where their problems were. They could raise a flag and call any time, but we actually went back to them every quarter and said, what are you, where are you at? What's your highest stress and how can we help meet it? So we really tried to combine that antecedent thing that they had with the retrospective thing of the hospitalization. And we built this team around that actually really tried to resonate with the families. And I think a couple things. One is, I think I showed you our data, and by having this prospective and retrospective review, and then I know that over time we use the FESET, which is just a tool that has been developed that actually looks at family engagement, and that really improved as well. So I think we did a bunch of things. This is a dynamic process, I guess I want to say, and I know that that's a challenge, but I also think it's something that we're hoping to that you'll consider supporting.
Okay, well, that's helpful. So let's just get to the support, and I know our time is limited, so I know the conversation is about how we might be able to help support, and I'm guessing, but you can tell me that the grant dollars you have are running at the grant has a time frame and it's running out.
Right.
And so now the question for you is, how are you going to afford to these new folks that you've hired and whatever other costs are associated with the screening process and the planning process and so on? Is that correct? Am I correct? When does grant?
You are right on.
Okay, how soon does this grant run out?
Well, it's May now, and we have a report due in June, and then we're supposed to be done in September, but we're hoping we can get another year.
Okay, so
but we don't have it. That's not guaranteed.
So anywhere between 3 months and 1 year. Well, let's hope for the 1 year, given how challenging it is to get support from Medicaid up and running. So you mentioned the $1,800 savings. How does that compare to how you would cost out what it's costing you for personnel and for all this activity? Is it neutral? Is it right. Savings, or what's your understanding of that?
So we are looking at the cost of the personnel and our 345 kids. And I haven't done this math more than on the back of a napkin, but if we could do something along the line of $75 per member per month for this group, and of the 345 kids, I want to point out that about 250 are in Medicaid. If we can do $75 per member per month, we can afford to sustain the program. So that's what we're really looking for, is to figure out if there's a way to do that. I want to bring up one other thing that I think is really important before we close out. And I guess that's this, is that we know that kids are dynamic over time. So we want to make sure that Medicaid gets its value. So we're willing to say, okay, let's reevaluate each of these kids every year and a half to make sure they should still be part of the program. Because we know that we know that some kids get better, thankfully, and some kids continue to need care. And so that's kind of where we're at. I know you have to go soon, but I wonder what would be the next things that we could get you guys to get involved in? Would it be the data? Would it be helpful for you to see some of our financial things? What works?
Well, I think it's a large team here at Medicaid, and a large number of people that would have to weigh in and understand this, from people who aren't going to understand all the words you used about care management, Who are going to need, very precise examples of exactly what folks are doing. So I think a better understanding of the team and who folks are and what their licenses are. You want to make sure that folks are, if we're supporting something, people are operating within the scope of practice. So Medicaid has to worry about that. I think, more detail on the number, the 1-pager, 2-pagers was interesting, but I think more data on what you
Right.
saw, how you're defining preventable hospitalizations to make sure we have a way of doing that, but to make sure that we're on the same page about that. So we want to look at that and make sure that, for example, that the decrease in hospitalizations, that you actually have all the data that you have that on that patient, because you may or may not know when somebody in Medicaid gets hospitalized and goes out of your region or even out of the state. So we might want to share some precise information and make sure that those numbers are real. I think understanding a little bit more about how you're defining the population would be helpful. And we're going to need to think about whether these kids are in managed care plans or in fee-for-service. We know we have a mix. And the approach and the conversations. But just out of curiosity, have you broached this with any of the managed care plans, either the Medicaid plans or the commercial plans, and what's been their response?
Well, we have one plan that's the nonprofit plan up here. It's People's Pretty Good Managed Care Organization.
Yeah.
And they're willing, they're interested. But the commercial plans are kind of like, they feel like they do this work already, and they're really more reluctant to support us. And even People's Pretty Good are not super interested in. They still have their care plans. We're actually talking about whether their care coordinators could come to our clinics as sort of a interim step. But we kind of like our model. And as you probably know, because you were in primary care at one point, we think that the closer you get to the providers and now to some of the community stuff, we have a better chance of actually making a difference here. So,
one of the things that we'd want to sort out is, how much of this is duplicate or overlap with what plans are doing, or, we have a disease management vendor now that reaches out to individuals based on some of their diagnoses. And one of the things that we'd have to be clear about is that there was not overlapping services or some confusion that way. So I think understanding who these kids are and what the implications are would be an issue for us. And there's some challenges. I don't need to go into all the details about the machinations of the Medicaid program and how we'd have to consider essentially a new expenditure. It depends on the amount, depends on in what form, depends on whether it's currently a covered service or not. I mentioned the managed care and the fee-for-service issue, as well as we have this weird thing called statewide-ness, where if we offer benefits to individuals in Medicaid, and we're not offering it to everybody, we have to justify or explain why that is, and so on. So there are a number of things that we would need to think about internally. We might need information from you to be able to make some of those arguments. I hope that, we could continue the conversation about this.
Yeah, that's exactly what we'd like, is to be able to figure out a way to continue the conversation. I just want, we wanted to introduce this to you. I have a 1-pager I brought that I'm hoping that I can give you a few copies of, and then you could share it, because I just feel like, that may help you introduce this to some of your managed care staff or your care coordination team, whoever you need to. I'd like to really get that kind of looped back in if possible, so that we could figure out the next steps. Can I leave that for you? And would you be willing to connect us to some of the staff that we should be talking to so we could keep this conversation going?
I'm happy to do that. I think probably you want to expand out and get more information before knocking on other doors, or certainly before talking to the Medicaid director. But I think I'd be happy to do that. I think, you mentioned social determinants, as you know, it's a big issue for us this year. And it's a big issue currently about social risk. I'm just curious if the program you have addresses healthcare disparities in any way, and because that's something that we're being asked increasingly to pay attention to. And I'm just wondering if the data that you have speaks to any issues about disparities based on race and ethnicity and geography and so on. If you do, I mean, those are some of the things I might get back to you after this to have you, even if you need to go back and take a look, that might help us to be able to help you figure out whether this could be prioritized.
Yeah, I think we'd certainly be willing to look at that. We have some demographic data on the kids we're serving, and, remember, we're, a rural program. So we know that some of the rural poverty issues come in, as well as some race and ethnicity ones. But let's do this, if that's okay. We definitely are here to introduce this and to work with you. We know that this is the intro meeting. So why don't, what's the best thing to do? Do you want us to write up some ideas for some of the things you were talking about, or do you want to pass us along to somebody else? What's the best way to do the next step?
After the meeting, let me put down on paper some of the things that we could use, some of which you may have available, some of which you might not, and that's fine. We're not asking you to make something up that you don't have.
Right.
And then we will plan another meeting. It would be great to have some of the other parts of your team as well. So, you were very helpful and eloquent, and, I respect the leadership position you have. It would be great to hear, even you mentioned families. If there was a family member that was willing to come in and talk a little bit about, provide a little bit more detail about what are the cracks as they perceive them in healthcare, and what was done that was helpful. I think just amplifying the message and hearing from others would be interesting.
We would love to bring in some of the families. They keep us going. So, alrighty, let's wrap this part up. I hope no Academy Awards for sure, but at least we got somewhere. There's Foster, thank you for playing the role. And we thought what we do is have a little conversation now about this, just because we wanted to illustrate how this went. And I guess I'm just going to say one thing, and that's we wanted to form a relationship, and we wanted to have a next step in this conversation. And those were the things that I was really hitting for. We're not going to get to everything, as you guys know, your programs are really detailed. Rich, do you want to go through the comments, or do you want us to go through what some of the things that Foster and I went through, or maybe we'll go through the questions, and then then people are welcome to add more to as well.
Let me just say, I was a lot nicer to you than probably I would have been to somebody A, I didn't know, and B, in really playing that role. But I take instruction well.
Well, Foster also said something to me when we were planning this that I think is important, that, if you're in Medicaid, you get a meeting like this every couple of days, or a request for one, and you have to decide which ones are really just which ones is there enough credibility behind the ask that you want to even have a discussion with them. So, and I think you guys bring credibility to say that, so you're more likely to get that kind of meeting if you request it, but you need to come prepared.
Yeah, so Jeff and Foster, that was great. I've been tracking questions in the chat. Heather, we have how many minutes, Heather, for some Q&A and discussion, please?
Yeah, we can go up until about 1 o'clock, and then we'll go back to Jeff's slides.
Okay, all right. So I think I really appreciated, Jeff, what your strategic goals were to make a connection in the next steps. And I thought that was really great. Foster, I think that you were sufficiently open, but also not really promising anything. So from my perspective, I felt that there was quite a bit of realism there. I'm going to make a couple of observations, and then I'm going to tag some of the comments and questions and observations in the chat box. One, Foster, I think toward the end, where you explicitly called out focus on disparities is quite a critical opportunity for those of us trying to advance care coordination for kids with special health care needs. So I consider that a strategic pearl. Foster, I was impressed when you talked about overlapping services. Who else is doing this? A vendor for case management. How and if does that align with what Dr. Schiff and his team has demonstrated? And then finally, Foster, you also talked about scope of practice. And for those of us in this space, as clinicians, we say, oh, but otherwise it's not being done. But I think for our Academy membership, recognize that these are really important things from the perspective of the agency. And so what I'm going to put a couple of questions out there. And one from Teresa in Michigan. I think that many people wonder why care coordination done in a team is different than care coordination that's done telephonically by a case manager in a managed care setting. And she's calling out this notion of individual touch, accountability, and relationship based. So I'm wondering, in the context of the dyadic discussion that you folks just had, and I'll leave it to you to decide if you want to step back into character or not. I think Teresa's really touched on something that families have been saying literally for years, if not decades. So some thoughts on that element, please.
I think it's I'll start, Jeff, if that's all right. I think it's a really great point. I think if for nothing else, people throw around the term care coordination, care management, all the time. So I think being clear about about the what, which was part of the question, which I didn't push on, which is give me more specificity about exactly what you're doing and who's doing it and how it helps. So being able to define what you mean by it, and I think as you said, Rich, being able to differentiate what this is from what a health plan may do or what a vendor may do, even with examples, if you have patients or family members who've experienced those. And so you can compare and contrast. And it might even be something to consider putting on, maybe not a 1-pager or 2-pager, but in that follow-up document that makes it crystal clear why this is not any of those other forms, how it differentiates. And I think a real question to ask a payer, Medicaid or plan, about their experience with other kinds of care management is, did it work out as well as you thought it would? Because the honest answer for most of these programs is no. They didn't work out the way in which payers had hoped that it would work out. So I think asking that and exploring that with them can be useful. Now, if they say, yeah, it's been great, you might want to push a little bit more on what exactly they did and how great it really was. But I think you'll find a lot of people have been very disappointed with it, which is, again, it's a challenge to be selling care coordination, because there's been a lot of care coordination, care management that's been sold that hasn't lived up to expectations.
Yeah. And
Rich,
Foster,
can I add something?
Yes, I'm going to hold. Go ahead. You go ahead, Jeff.
I think that I'm going to say this sort of academically and then not academically. You are valuable because you serve as an agent for those patients that does not have a conflict of interest most of the time. A primary care doc is not going to get more money if somebody has an extra surgery or an extra hospitalization, or is not going to save money if the managed care organization doesn't have to pay anything out. So in a healthcare system where there's way asymmetric knowledge, the providers will always know more than the families. You acting as an agent to guide their care is really valuable, and you need to tell Medicaid that, because you don't have an incentive, hopefully, to overtreat, and you don't have an incentive to undertreat. And the managed care organizations, even though it may save money, and foster or somebody in Medicaid may say, well, great, this managed care organization is saving money. They also get a lot of complaints from families about how care is restricted by care management that is really utilization review. So you have to sell your unique position as an expert and as an advocate, but you also have to say you're willing to be a steward.
Yeah, critically important. Perhaps the simplest but most compelling statement that or question that Foster raised in the enactment was, so what is it? And I think that this is something that our Academy participants have actually spent a fair amount of time articulating what it is. What's the intervention? I know the CHOC team in particular has done a lot of work articulating care coordination. What is it? What are the activities? And that what we call that value stream analysis. So what is the it? How does it differentiate from existing resources is critically important. I'm going to try to connect two, I think they're both from Montana, points back to you for reflection, Jeff and Foster. Tara Thomas, integration of healthy and informed parent peer supports as part of the care coordination team is an excellent lived experience way to support families with social, emotional, and navigating aspects of these complicated systems. And I want to put that next to observation from Suzanne, who basically says, how are you taking into account possibly some sensitivity around vulnerability for families, quote unquote, needing extra help to navigate a system. So I'm wondering if you guys could reflect on both this as a way of empowering families to navigate the system without calling out the fact that they're not achieving to the level they need to. And then Tara's notion of, families that have been on this journey before are a pretty robust resource. So Jeff and Foster, what do you think about the family aspect?
Do you want me to go first? So I guess I want to honor the fact that I didn't, in this example, put a family support person as part of the team officially, and I think that's super important. I think especially when we get into communities where there's big disparities, that is because I want to say it's a great way. You all have more experience than this. You've built teams that included families, and you have structures that actually support families. I want to honor two things. One is that right now, with all the work that's been done on disparities, it is a way to connect to something that's hot button for folks in Medicaid, for sure. And hopefully will stay hot button until it gets resolved, not just be a shiny object for a while. So I think that that getting engaging and using the family partners that you have is really a wonderful way to do that. I also just want to honor the fact that those folks need to be supported as well. So I think figuring out how to have them as part of the team is really crucial, and I think that's something that can be very real in teams that are based, as most of your teams are, in directly in the service in primary care. So I'll stop there.
Foster, anything to add?
Not much to add. I mean, there's nothing there to disagree with. I think in terms of making the argument to payer, it's compelling and important, I think, to have a family or patient voice. I think it may not seem as if, the bureaucracy as big as Medicaid or government insurance or a payer is attentive to individuals or individual stories. But I've seen in many cases how much a face to a problem or an issue or an opportunity really makes a difference. So, humanity and humanness and the way in which people respond to faces and body language and actual stories is, can't be underestimated. It's not the only thing to arrive with, but I think it's a really important piece of this and can help actually move action. It's harder to ignore, and I don't need to tell this group how important the advocacy of families with children with special health care needs have been historically. That influence, that power, that relationship has not gone away. I know it feels like everything other than COVID has gone away, but it's still there.
Yeah. Yeah, and I've just gotten permission from Heather to bring one more comment out, and I was trying to figure out how I was going to sneak it in. So Maureen from Texas, you have articulated, as far as I'm concerned, possibly the single most important strategic priority for those of us that think about measurement and outcomes for children with medical complexity and children and youth with special health care needs. And it really parlays nicely with my colleague, Mike Weiss from CHOC. Mike's talking about basically what he's saying, the it varies, which is to say the value proposition is often different between commercial plans, Medicaid plans, and it is also different from the perspective of the providers and the families. But Maureen, you've shared an incredibly important point that I want to bring to our faculty here. Parents speaking here, when pitching to funders is cost saving, the only outcome that matters are, quote, soft outcomes, such as reduction in caregiver stress, worth highlighting. So Jeff and Foster, as you both know, I have a strong opinion about this, but I'm going to hand it to you guys.
So you're going to go?
I want to make sure I understand. The question is, does it make sense to include quote unquote softer outcomes in making a pitch about cost savings?
Exactly right.
Yeah, why not? I mean, again, I think that is the only thing is problematic depending on the audience. So, given that a decision about funding at least a large program or a small program goes through finance people, the finance people in an organization, including many of the organizations that you all work in, don't know from quality of life, social determinants, family stressors, all the, they know what they know. So I think, you should imagine that the eventual audience for something is, complicated with as many moving parts as Medicaid to say yes to involves people with a lot of different backgrounds and interests. So there's no harm in including it. I think the problem is that if it's only the softer outcome. So Jeff talked about preventable hospitalizations, which is a terminology that's become very familiar to payers. Talked about standardized metrics on quality of life, and I think those have come a long way. And I think the other thing is to include and think about in costs, which depending on the audience may or may not be compelling, is what are the potential costs to the families? Not a direct cost to Medicaid, perhaps, at least not in the short term, but what kinds of cost avoidance is included in this, and what kinds of potential cost savings related to the ability of parents or caregivers to work, for example. That's not something that Medicaid specifically has a way of scoring, but again, depending on the audience, and if the audience goes up the food chain to executive chamber to governor's office, thinking about those sorts of other cost endpoints may be important as well. But Jeff, do you have?
Yeah, Foster, I agree. I think that I want to sell this harder in a way, because I think if you're in a Medicaid agency and somebody came and visited you and they gave you a bunch of data, you kind of go, yeah, thanks. Right. But if they can tell you a story, you're going to remember the story. And the stories are really the powerful illustration. I think there's an ethics to this. Yeah, the story has to be about something that really happened that you're doing, not something that you're theoretically made up, or, because we've had that happen, or somebody, or about the exception. I think that, stories are data with empathy attached, and I really think that when that person in the agency or in the managed care organization then has to think about whether they're going to spend that time to pass that email along, having that story in the back of their head will really help. So I want to make sure that that it can't be everything, and you have to play to the person, who you're talking to, but that's not disingenuous, right? That's just the way it is. You're selling something that we all believe and we all know we need. So I think that if you could sell it in a way that makes people feel like they're really part of that they can be part of something important, it's crucial.
That's
guys.
wonderful, and it's a great segue back to Heather. Now, Maureen, that is the North Star, and I want everybody in the Academy, if you have 30 seconds, take a look at the chat that I just put in there, because it is something that is one of the legs of our stool. So Heather, back to you, and Foster and Jeff, that was absolutely wonderful.
Yes, guys, that was great. I do think it deserves Academy Awards. I think we can use a pun with that. Thank you so much. So now we want to talk a little bit more about how can you prepare to do this? How can you work as a team to get to this point where you're able to go to a policymaker and have a conversation like that? I will share the screen again, and we'll go through some slides that Jeff has prepared, where today we'll walk you through sort of the who and the what, but then we'll talk a little bit more about how future sessions will continue to dive deeper into this.
Great.
Let's see. Do you have the slides up?
Yep.
Can you see them, Jeff?
I do.
Perfect.
So,
all right, go ahead.
So we're just going to pivot a little bit, because I think what we really want to do is hopefully prepare you guys to have some conversation like that. And I want to, maybe before I start this, I just want to say a couple other quick things about the discussion we had that I saw in the chat. One is somebody talked about data. If you don't have data, don't lie about it. But if you don't have perfect data, don't beat yourself up about it, I guess is what I really want to say. This is not an academic presentation to a national research forum. This is about telling your legislators what they need. And so I think there's an honesty there, but about what you have and don't have, but there's also a need to convey data. And I kind of always think about this in terms of what data folks would come to me about, and then how you wanted to be better than folks who are just trying to sell something and not telling the whole truth, but you want to make sure you talk about it, and including if you have some data about the family impact, not just the stories. I think those things are really crucial. I want to say that before we even start this, I put the Perseverance rover up here because I want to have everybody remember that this is perseverance and persistence. And if you're in this academy and attending today, you qualify. Because we all have been at this for a long time, and we just want to move. We really want to move it to the next story. And then the last thing I just want to say, just to add to the stories, is relationships are really important. So sometimes it's one person whose friend is the grandfather of somebody who needs services that makes all the difference. So, and that's the way things really work. So I think that I just want to say that. But having said that, I think our goal here with this is both to sort of demonstrate sort of what the ask looks like, but I also think there's a really important part of this that is that continuation of the conversation that we really want to continue to have happen. So what we really have talked about in the Academy planning is about hopefully going, as Rich said, to giving you guys a tool. So we're really hoping in the next few sessions of the Academy, we'll get you guys to write your tool, so that you can go not empty-handed, or not with a bunch of, not with 100 pieces of paper that have a lot of graphs, but with something that you can leave with legislators. And as the legislators and the legislative staff have said, is if it's not on 2 pages, we're not going to read it. A lot of people will be honest about that. So you have to take all your work for years and you have to synthesize it down to just a couple pages. And I know that's hard to do. So we want to spend a couple some time today talking about who and what's your who strategy? And we want you to do that in your teams, because we really think that it's important to figure that out. And I know that in some of the conversations we've had with some of you, you've had different groups of who to go to. And I know that some folks have to sell this internally. Some folks have to sell to their Medicaid managed care, chief medical officers, Medicaid officials, legislative staff, or legislators. So those are kind of some of the who we feel like we need to talk to. Sometimes it could be the who could be your partners, who are not so on board. But I think that figuring out who you want to sell, you need to sell what you've been working so hard on too, is the part probably first of this. So that's one thing we really want you to work on when you have your conversations, because we really like to come back and say, in my state, I need to get to a legislative staff, or in my state, I need to just get to the chief medical officer of my 500 member group and see if they're willing to give us more support or to let us go further. Next slide. This is what I've said, the 1 or 2 pager, depending on whether you count. I don't think it should be more than one side, both side, 1 page, 2 sides, but that's probably okay. It gives them the ability to pass the message along to different audiences. So when you have something like that, it's a tool, because you leave it with Foster or with, a managed care director, and they have it, and then they either or you send it to them electronically and they start passing it along, and then that allows you to see where it goes. If you don't have something like that, the conversation Foster and I just had becomes Foster's synthesis of the conversation down to 2 bullets. This group wants money. They have some results. Please look into it. You know what I mean? Where if you have something more like this, you can pass it along, and the data people will want to say, well, what data do they need? The managed care contracting people will say, this is what we need. So it allows and then the other thing that I think is really important is that if you develop a 2-pager with your team, everybody owns it. And like I'll show you in a sec, this 2-pager that got worked on in a project that we did, and everybody's really proud of it. It's not everything. Some people would tweak it a little bit, but at the end of the day, it's what everybody holds on to and says, this is the product we created. This is the feature film, that we could share with everybody. There's some stuff that's on the cutting room floor, but this tells our story. Next slide. I want to just say that some of you who are in the CoIIN have been asked to create impact statements, and these are the elements of the impact statements: a statement of need, a project summary, impact, and collaborators. And here we're asking you to go to somebody for financial sustainability and have an ask. So some of the elements will look similar or parallel, but I just want to say that some of those statement of needs can be around other specifics within your program for other audiences. This one, we're hoping that you'll develop with a specific ask for folks who can help you sustain the program financially. Next slide. So what are you presenting? Next slide. This is one that was developed for a program we had in Minnesota. And I just want to bring this up because I think this is a good example of what a 1-pager looks like that you could leave with somebody. I want to point out first that there's this thing about what the opportunity is and who we are. There's facts about the problem. There's quotes lower down, and I'll get to all these. And then there's an ask, and there's contact information. So you're leaving everything you want. What this one doesn't have, I'll just be honest about it, it doesn't have data yet, because this program didn't have data at the time of this project. So next slide, just to focus on a few of those things. So you can see them is the opportunity. This is about what the problem is, who this group is, which is a group that that was started in the community. So it's really quick. You don't have to, you can read these things, and some people would even argue that these are the font is too small and there's too much said, but I think it's important. And then next, this is the policy platform. This is what they really want. Okay. And so, support standalone integrated integrated care for high-risk pregnancies funded by the Minnesota Department of Human Services through multiple community-driven partnerships. So they want money, right? And then long-term strategies. And so all the things they want are really clearly highlighted. They're not highlighted in a detail that says, we need $75 per member per month, because that's probably not the goal here. You don't want to over ask for specifics, but they're highlighted in a way that says, we want you to act on what we're giving you. So I think that that's where you have to figure out that nuance, and depends on who the audience is, because it may be we want you to pay for the family partner and going forward. Okay, next slide. Quotes. This particular program had quotes from that are national. But I think I love this first one. It is hard for American healthcare professionals to get their heads around that when you have an organized community-based team that connects technical clinical issues with deep embedded set of relationships, you can make real breakthroughs. I think in some ways you guys are an example of that. But anyway, I think the quotes are really good. You can take a quote from your own families and use it, but a quote in big font at the top of a page or somewhere on a page is what somebody's going to look at first. And that's what they're going to remember. That's the part of the story they remember. Or you can hook them as you go and present and talk about that quote and who that family is, or bring that family person with you. Next slide. So, the what is on what you do, what's unique about what you do, the population, the quality of the service, the longitudinality of care, and what is different about what's being done now. Next. This is stuff we'll get to probably a little bit later, but these are the other things that are on there. What's the personal story that you want to tell? What's the data you want to present to generalize that story? Next. What's your ask? And that's sort of what was in that colored box that we just showed. First, you want to inform and list commitment and expand the meeting. That's what we did in that role play. Eventually, you want money, MCO contract language, Medicaid change, co-author, something bigger, but you want to get these people to kind of own this with you. I think that's when you know you're successful. Next. I want to bring this up because I think it's important. Know your opposition, and the opposition doesn't have to be somebody, else who wants to do this service. It could be something as simple as Medicaid programs are overwhelmed. They're overwhelmed with COVID. They're overwhelmed trying to figure out how to do things around disparities. But I put a slide up that I got from one of the advocacy organizations. Next slide. And I think that down on the bottom here, it's really a box that says what we say about ourselves, what we say about our opponents, what our opponents say about us, and what our opponents say about themselves. So you should know that. You should know that even if the opponent is time at the Medicaid agency, you need to be able to at least acknowledge that that they have issues. You know what I mean? So you need to bring decision makers in. I don't think it ever helps. This is probably more Zen than anything, to go after somebody and say they're worthless. You don't know these people. Nobody ever does well by dissing somebody somebody you don't know. But if you can just say, we know that they've tried this, care management at the health plan level, and it just doesn't seem that the families are really connecting to it, you know what I mean, or something like that. I think it's really important. But I think that if you do a little bit of that, that's also really helpful. And next. So today we really want to just go through a couple things we want to talk about. We want you to really ask in your workshop sessions, who's the target audience for the message? Who is the message coming from? So I played a role of a provider, but I think that was not the best necessarily. It could come from a different group. Who should deliver the message and who should the message go to? What's the key content of the program you want to express? What do you do every day that they don't know about? And how will you tell that simply? And then if you could get to today, what's the story or a quote you would put on a one pager? And remember, we're trying to build this so that you have a document at the end of the day that says, here's what Montana's doing, here's what Indiana's doing, and you guys can say, here's the story we want to tell. We can send this around to 100 people or to our mailing list and really get agreement on it. So that's the story. That's where we'd like to go today. Next slide. In the future, we'll talk about data. We'll talk about data we can give you guys from national experience as well as your local data. We can talk about your ask. We want to remind you each of these times to talk about being persistent and to persevere. We want to make this look fun so that you have something at the end of the day. So that's where we're at. Next slide.
Okay, I will just
Heather,
jump
back to
in.
you.
Yes, and I just want to clarify, so at the end of the day, we don't expect by the end of the day today that you will create a one pager, but this will be sort of going forward. You'll start to build upon this and then eventually have something similar to what Jeff shared. I want to acknowledge in the chat that people have asked that we share the document that you pulled up, Jeff, on the integrated high-risk pregnancies. We can definitely share that on Open Pediatrics along with the slides. Everything from today will be posted by tomorrow. When you come back from break in the chat, I will be sharing, we created a template for you to make your one pager and also the breakout group instructions. So feel free to go ahead and take your break and come back at 1:30 and then we will go off to breakout groups.
Great.
Thank you, everybody.
Awesome. And the worksheet will be there then too, as I think Heather just said. Thanks.
Correct. All right, I'm going to start sharing stuff in the chat, but everyone can feel free to be on break. Great job, Jeff.
Thanks.
And I will pause the recording too.
Mary, appreciate that.
All right, so everyone should be back from their breakout groups. We'd like to now spend the rest of the afternoon till about 2:55 doing team report outs. So if there's anyone that wants to volunteer, we'd like to discuss, how did it go in your breakout groups? Were you able to identify your who and what? Did you have struggles identifying those? If there's anyone that wants to kick us off, we'd love to hear from you. You're welcome to unmute and just go ahead and talk, or you can also put your thoughts in the chat and we're happy to share them for you.
Hi, Julie from New Jersey. Almost said New York, my goodness. I worked in New York too many years in my life. But we had a very robust conversation. And the more we tried to answer the first question, we ended up with 10 other questions. That's okay. So we're a target audience. We're thinking about looking at maybe school engagement, doctors, Medicaid, you name it, anybody and everybody. And also the team together is going to do the whole message. It's going to be from everybody. We want to care for the whole child, breaking down silos, coordinating the services, 2-generational shared care plan, family medical home, and let's see, what do you do every day that they don't know about? Bringing all the services together, which is very important, and starting the conversation between the providers. Closing the loop, working with the MCOs to align services. What story do you want to tell to identify help the family identify what the highest priority is, what's working for them, what's not working for them. Let the family know that they're a member of the team. Pretty much the family and the child is the center of our team. And more of a conversation will come soon.
Very cool. Julie, I think you hit on something I just want to compliment you guys on, and that's that you have multiple audiences and the message may be a little different for each of them, but getting it down into one thing that you all agree upon will give it some strength and be able to spread it more broadly. So very cool.
I
Thank you,
agree with
Julia.
that. One of the interesting elements of the so-called Inc. grantees is that they were defining trying to drive a meaningful relationship between the payers and the providers. So I was impressed, Julie, with the idea about how do we pull other providers in and get the communities going. I look forward to seeing how this evolves going forward, especially the financing model.
Heather, this is Stacy in Alabama. I'll go next, if that's okay.
That's
Please.
great. Thank you so much,
Yeah.
Stacey. Nice to see you.
Nice to see you. We had originally for our Care Coordination Academy, we are piloting. We're not quite there yet, but we're working towards piloting tiered care coordination. So for this specific exercise, we actually combined that with the work that we've done in our CoIIN. And we focused, we took a lot of, we had an open discussion and then came up with a statement for the, what is your issue you plan to address? And we came up with, there is a need to improve care coordination for CMC in our state. Current care coordination services are fragmented and specialized care coordination services do not exist. There is a need to expand the CMC CoIIN model of providing comprehensive care coordination with providers that serve CMC to improve outcomes for CMC that focuses on patient and family quality of life. That is a first draft of our statement. But we had a lot of good discussion about the need for specialized care coordination for children with medical complexity, and talked about spreading the model within Alabama, which we've talked about a lot in our CoIIN project. And we're in the process of getting some data from Medicaid to see where children with medical complexities are located in the state to identify potential practices to talk to about our successes in the CoIIN and our future successes with tiered care coordination. So that's what we talked about.
Stacy, and we're trying to just get through all the teams, so we're going to be very parsimonious. One question that I have, you mentioned some of the successes in care coordination. What are you doing to capture those? Are they stories? Are they quantifiable? What are you thinking about for labeling that?
Right now for our CoIIN project, we focused on some qualitative information and that we've collected through the project, and then we'll look at our quality measures and data surveys to see if there's things that we want to highlight from that. But a lot of it is there are outcomes from the actual CoIIN, from the physicians at the pediatric practice where we were located, from our care coordinator, and from the CRS office.
Thank you.
Mm-hmm.
I can go next. This is Katie from Philadelphia.
Yep.
So our project, we're doing integrated care for kids in partnership with Dr. Turchi's group at St. Christopher's Hospital. And so we're actually already funded through Pennsylvania. Our Medicaid program has a new requirement, a community-based care management requirement. And so we lucked out with the timing and are funded to do this. So, but the one thing, we're like in the midst of hiring staff at both at St. Chris and at CVH, the payer, that would be co-located on the grounds of St. Chris as part of doing integrated care. And so the one thing that we talked about is in this year, we actually budgeted, like we have additional funds, right? Because we're still launching. So we're not going to spend a full year's worth of money. And so we're reallocating funds, and we're hoping to do things like respite care, because we know that there's been increases in child abuse, neglect, and some pretty awful outcomes. Families need breaks. And we're looking to increase maybe some of the funding that's going to our community-based organizations. as some of the ways that we're repurposing money this year that we wouldn't necessarily be able to continue into next year's budget. And so the one idea is to do, one pager and infographic on that would be geared towards funders that Dr. Turchi seems like an art form of securing support from. So if we had the pitch on what our integrated care for kids model is, what it looks like, the types of areas that we don't have support or enough support from Medicaid. We are able to do a lot actually with the funding. Like we are paying for the medical legal partnership, and we are going to pay for another CBO to be on site. And then the evaluation piece would be, so we would really, I think, use it to try and, if we get respite care, expand it in Philly. I don't have that in the budget for next year, but we could make a pitch to a nonprofit maybe to support some of that. And so we do have funds in this year's budget to do some evaluation work, focus groups with families that have received care coordination, primary data collection, to capture the family engagement and their family experience in care coordination. And so some of that stuff could be really helpful. We could use our outcomes data along with testimonials from family members that have benefited from these connections as part of making the case. So that's sort of what we were thinking about. How do we, if we start something good and we don't have it in our budget next year, how do we find someone to help us continue it? We think it's important.
That's great.
Hey, Katie, this is Jeff. Can I just ask you, you sort of described the sustainability process here in a way that, you can add things and then look for funding later. You already have some. Where did it all start? Like some of the teams, I think, are really figuring out how to get the first dollar in the door for this. Like, did you I think you're a clinician or a administrator in that, did you, who did the lifting to get the relationships to get that started? Because you're on probably on one pager number 10 or something.
So I work for the payer, right? So CBH is in Philadelphia County. We're the behavioral health managed care company for the whole county.
Right? Okay.
We're a little different. Pennsylvania is still a carve out state, and we're kind of embedded within the government. So when CMS had the integrated care for kids grant, I'm actually a researcher, and I finally have carved out my position at CBH to get to do grants. And so we did go, I said, I never talked about a failure so much in my life. So we went for the CMS funding opportunity at the time in partnership with Penn and CHOP, and we weren't funded, but leadership made a commitment to the vision. Because of course that was a ridiculous amount of work that a lot of people were a part of. And then conveniently you guys, that's when we met Dr. Antonelli, and then you guys did this. So we started to work on this just as the state conveniently, like the stars just aligned for us, which I was still shocked. And then the state came out with this new requirement, and they came to us and said, tell us what projects you want to do under this umbrella of community-based care management. And so we pitched Inc. as one of 3 projects, and they loved it, which was funny because when we went for the CMS grant, they were less on board. We had to convince them to support us. And by that point, we were already in touch with Dr. Turchi and having discussions about St. Chris expanding their scope of practice. And then so we have been working on our model essentially for, when was that? I think that was in 2019. So it's been at least two and a half years that we've been thinking about the setup and all that. Yeah. So that's, so this, the state, and right now the budget's actually the state's requiring that we contract with community-based organizations. I think basically, I feel like Pennsylvania is trying to do as much as they can without getting a waiver, is what I think. So the one place we got shot down on our budget is we did make an ask for a pretty substantial amount of money to be used as discretionary funds. And they said no. And it was, of course, I looked at all these other states that have the 1115 or the 1915I, is it? The waivers that allow you to do housing and some of those other things. And so we put a lot of that stuff that was already approved by CMS in other states. And PA said no, because we don't have a waiver. So I think this is as close as we can get without having a CMS waiver.
Right. But you've learned a lot I just want to point out, you've learned a lot along the process developed important partnerships. And I think the other lesson for everybody else in this may be that the first thing didn't work, so you went to plan B. Or,
Yeah, well, yeah, and from my personal perspective, it was a big deal that our leadership committed to us applying for the Integrated Care for Kids grant, because we didn't typically go for grants. And so I spent a lot of time being like, if we don't get it, because we might not get it, this is plan B. So I was doing a lot of
Right.
prep for plan B. And then when we didn't get it, everyone's like, we should figure this out. So no, it's all about relationships. I mean, I think from my perspective, what helped us get to the point where we are now is the relationships we had when we were applying for the grant, and then we shifted and St. Chris stepped up to be a great partner. And so a lot of it is about the relationships and good partners to pull it off, I think.
great. Thanks.
Sure.
So this is Rhonda from Minnesota. We can go next. Because we're a CoIIN team, we focused on financial sustainability. So our who we would pitch or will pitch this to state Medicaid director, governor's office, Health and Human Services committee chairs and members. And Marnie, if I'm saying this wrong, please correct me. Minnesota looks like they'll be doing some supplemental budgeting in the fall. I know that I don't really know how that works, but this may be an opportunity to make a pitch for some funding, so that the timing is good. Who the message is going to be from is going to be from our Care Coordination Academy team. But because some of our team members are from state agencies, we have to be kind of careful. They can't advocate either way. So the primary voices will be our complex care program and family voices, our family advisors. And then, the key is we want to balance our data. So Trisha had the most awesome idea. She pulled out her son's care map and said, really what the complex care program has done is they are coordinating all these different pieces. Because we realized, a lot of what happens with care coordination, nobody sees it. It's not a clinical encounter. It's not billed for. It's behind the scenes. So we wanted to make that visible. What we envision is a one-page document, but both sides. The care map, and we're going to come up with some graphic and how the complex care program helps pull those pieces together. And then on the other side will be data, some stories, some quotes. And I think I've talked long enough.
I love that, Rhonda. Yeah, thank you, Trisha. I think that's a great idea to show the actual care map and just show how much care coordination is doing to connect all of those different pieces, community, school, medical, social. There's so much being done, and it is hard to say and show what care coordination is, but there's so much. So that's great. Thank you.
Rhonda, I also like the idea of you having this strategy of who goes where, because at the state, you can't advocate. But if you have friendly state officials, they could tell you who you should talk to and what you should say. And, and it's sort of like they can be behind the machine. And I think that's useful, to make sure that they don't get out of their lane, but you can sort of honor their expertise and have them be part of it. And I think that's super important, especially because you're going to go above Medicaid in some situations. You talked about going to the legislature and informing advocates there as well.
Next.
I can go from Team Indiana. My name is Natasha. Our who is, we're in kind of communications with Riley Children's Hospital, so our primary children's hospital here in the state, Title V, and our Medicaid. Medicaid has been kind of long-term looking for Indiana. So right now, a primary focus seems to be Title V and Riley's Children's Hospital for sustainability over the next couple of years. And with that, a lot of the focus has come up to like who is presenting this to that team is IU School of Medicine, our resource and training hub for care coordination. They're at the School of Medicine, and that's been a primary focus moving forward for sustainability, is looking at how this team is training our care coordinators. So we have 3 care coordinators throughout the state. And we've been putting a lot of focus on how to train the care coordinators to provide care coordination. And that has been of a keen interest to the hospital and Title V. So looking at how do we market that on a broader scale as we're looking to bring more care coordinators, hopefully over the next couple of years in the state. So things like how are we talking about social determinants of health, different resources that are available, not only statewide, but very county specific as well. And then also training on communication skills. So things like motivational interviewing, trauma-informed care to engage with families. And so that's where our family to family partners are helping us out with as well. Yeah, I think that's the primary focus of what we were talking about in our breakout group.
Natasha, that's interesting. So you're aiming to Title V and to Riley, and where is Medicaid in that? Would they be after that step?
So I'm not 100% privy to all of that going on. That's definitely Dr. Ciccarelli, her primary focus. I think from the discussions that we've had at leadership meetings, that is a yes in the future, in the next couple of years, looking more so at the Medicaid home health waiver piece.
Yeah. And I want to call out for the Academy. This is actually pretty interesting. So what Natasha and her team are thinking about is we've got this nidus of activity, and let's see if we can expand the number of key stakeholders. And this is really an important lesson for the group here. So the journey to sustainability is closer to a marathon than a sprint. And so you may not be in a state where the Medicaid medical director is saying, I need something in my desk next week. So Natasha, I really like this idea of expanding the number of key stakeholders as a prelude to getting in front of the Medicaid program. Now that could change at any time, but that's how I'm deducing what you just articulated. And I think that's actually a pretty robust approach. And I'm thrilled that Title V is one of those key who's going forward, because the MCHB continues to be a proponent in this space.
So, Rich, I agree sort of, but I just want to say to Natasha, and I don't know, is that I think your Medicaid director is a pediatric ER doc, and having been a pediatric ER doc, you know, it's about relationships, but it might also be about timing. So you guys may want to say, well, what the heck, let's throw a Hail Mary pass and see if she's a receiver down at the other end, because she won't be there, you know, forever. So I think it's like, even if you don't have the exact ask right, you may have an opportunity for an alliance.
And so we're in, well, not me personally, but Indiana, Dr. Ciccarelli and the Medicaid are talking very consistently and keeping in touch and those kinds of things. So I think that, you know, back to the relationship building, that is something that we're always keeping in mind. And we're not putting all of the pieces in one basket, so to speak, and just continuing to touch base with the kind of 3 big players that we are talking with and seeing where they're at.
Great.
I can go next for Team Montana. In terms of the marathon that you mentioned, we're probably still in the training stages for the marathon. So our team is unique in that we are an entire state. We're not representing a practice or a region or a hospital. And so our efforts haven't always lined up with the assignments that are given for the teams. For today's assignment, for example, we were not able to come up with a one-pager because we're not at a place yet of asking anyone for funding. We don't have enough clarity ourselves in the direction that we're going. But that's not to say that we didn't make good use of the time. We had a very small group, but our team continues to network, to build relationships with one another, to learn who all of the different stakeholders are and what we each bring to the table, to identify the gaps. And so today we were able to further, I think, bring clarity to how we want to move forward. We've started a chart that lines out the differences between how the terms care coordination, care integration, case management, targeted case management are used in our state, who's using these terms, how they're using them, who's paying for the services, who's being served, et cetera. So we have a plan for continuing to fill that out and get it completed. We have a plan to move forward with bringing in more family voices. We have a number of parents on our team, but we want to bring in even more and identify not only gaps, which we've done a great deal of, but also identify some situations where it's worked well so that we can really pinpoint what's worked well and why, and who has paid for those pieces that have worked well. And then we also looked at the need for provider education, because there are a number of codes that are not being billed as often as it seems they could. So we identified some different ways that we could address provider education, recognizing that the providers in the state are so busy that sending out another newsletter article or inviting them to a training that doesn't offer continuing credit is not going to be a valid way of doing it. So again, we're in a very different place, but I think our time today was really productive in continuing to hone in on what it is that we need to do to make this a reality in our state. Thank you.
Kim, thank you for that. And you just very elegantly described something that we announced literally in the first day of the Care Coordination Academy, which is the Academy wants to meet the teams where they are. We don't even aspire to get everybody to the same spot at the same time, because that's impossible. So thank you for both being candid and also strategic. I'd like to point out a couple of opportunities, and at the risk of stating the obvious for the team from Montana, but for it's as important for the rest of the Academy to hear this. So the American Academy of Pediatrics and so did Family Voices received pretty sizable grants as part of the CARES Act to look at telehealth and virtual care. We're now in the process of looking at some opportunities, and I know that you've got at least one person who is a recognized national leader there in Montana in the virtual care for children with special health care needs. So to the extent that you're already thinking about building in a virtual component, and just to be clear, not just care provision, but the provision of care coordination, it puts Montana in a really important spot to be able to inform some of this other work that's going on nationally. Offline, I'm happy to connect with you and tell you who some of the folks are out there that I've been dealing with. But I commend your very organic approach to this. But because of that aspect of the resources available to Montana, I think that could potentially put you in a leadership position to demonstrate the value of virtual care coordination.
Excellent. Thank you very much.
This is Maureen from Texas. I'd be happy to go next. I am Maureen Benscooter. I am a parent representative on the Team Texas CoIIN. The target audience for our message is the Texas Health and Human Service Commission and Medicaid. And the message is coming from our comprehensive care clinic and the family work group of the CoIIN, together with our full team, which includes Blue Cross Blue Shield, one of our managed care providers for Medicaid, Title V, and the University of Texas Dell Medical School here in Austin, as well as private providers in the community. The key content that we want to express, to begin with, what you don't know about every day that we go through every day is paperwork, paperwork, paperwork. We want the total cost calculated so that the paperwork burden, which was designed in part to prevent misuse of funds, but creates redundancies, is factored into the equation. The cost of redundancies must be calculated so we can develop a system that minimizes inefficiencies all around. The system is inefficient and burdensome to families, providers, and payers. And we want to create a system that minimizes the waste and abuse all around, and in particular, reduces caregiver stress and improves child and family quality of life. And I'll close with a quote from one of our participating family members. Families of children with medical complexity have agonizing levels of distress sustained over long periods of time. Our frustration over authorization delays may seem extreme, but it is compounded by going through the same processes over and over again, and is layered on top of our daily, you wouldn't even believe it if I told you, stress. Thank you.
That's phenomenal. I mean, I think that's the kind of message that I think people won't forget, and I think it says it so well. So thanks for sharing. I think that'll really make it. I think you're well on your way to getting that ask down and
Thank you.
Making a difference.
That's 2 home runs in 1 meeting, Maureen. Thank you.
All right, I think my work here is done. Bye.
That's right. I'm going to applaud you non-virtually. Thank you.
It was a team effort for sure. Thank you.
Hi, I'm Teresa from Michigan. Can you hear me?
Yes.
Yes, we can, Teresa.
Okay. Michigan has been working on a model of care management for children with medical complexity as well. As many people may not know, Michigan is actually part of the Medicaid system in Michigan. We belong to the Medical Services Administration. And so we have been working, partnering with the Michigan Medicine, which is known as the University of Michigan in many places, with their Partners for Children program, and then also with the Michigan Health Endowment Fund. And so the project that we're looking at is hoping to develop a team-based set of services that are very intense, focusing in on care coordination and case management, and can be offered on and available 24/7 a day. And these services can also be available in the home-based setting as well as via telemedicine. So our next step actually was to create a 1-pager. So this meeting became very opportune for us to be able to focus on that, because that's exactly where we're at. What we're hoping to do is distribute this, what we call them our white pages, and this will go to our MSA leadership team, as well as to our partner organizations and our Children's Special Healthcare Advisory Council. And then also to some of our other stakeholders, which would include some of the palliative care providers within the state, as well as what we have our children's multidisciplinary clinics. And so we want to make sure that we share that with them as well. And so we're seeking to, be able to, on a high level basis, to provide an overview of the services that will be provided, explaining why they're unique to the services that are currently available, and then also be thinking about sharing some of the information that we've already identified as being cost savings related. We think especially for the MSA, for our own leadership, that will be important, is to understand about the cost savings that can be accrued through a decrease in hospitalizations and decreased costs related to hospitalizations. And we want to make sure that they understand that. And so we'll be using that information as well as a basis for putting together a state planning grant that is going to be looking to establish a health home. And the health home becomes the vehicle then to provide these services. So today's session was very good for us. Of course, we're going to be looking for a quote. We believe that there are going to be some important stories that we'll be able to get from our partner providers. And we want to make sure that, that we put together a really nice piece, because we think this is very important work. And we want to make sure that we get everybody on board and moving forward. And
Teresa, do you have the state planning grant? Is that funded already and you have to apply for it, or is that something that you're hoping somebody will fund?
the state planning grant will be through CMS. They offer a state planning grant for health homes. It's a $500,000 planning grant. It requires a 2-page application. So again, this was very fortuitous that we were able to participate, because we really think that the information that we are going to develop as a basis from our participation in today's meeting will be helpful for securing those funds.
Great.
Great stuff. I think we have 3 more teams.
And we might not be able to get to everybody, but we can try to squeeze in at least 1 to 2 more. Is there anyone that wants to volunteer to go next? Otherwise, I'm keeping track. I know who's still out there.
So I'm Karen Pugh. Can you hear me with Team California?
Yes, thank you so much,
Hi, Karen.
Oh, I think you just froze.
You just froze.
Let's see, does someone else want to go while we're waiting for Karen to get back up and running? Is there anyone from Florida or one of the spina bifida teams that wants to give a quick summary?
Hi, Karen, do you want me to go? This is Annie from Talk. Are you back or are you still frozen? Oh.
Can you hear me?
Yeah.
Okay.
Okay.
So I'm Karen Pugh with Team California, and we wanted to take it from a perspective of the work that we're doing with our CCMT. So our target audience, we felt that we had a few potential audiences. First being our organizational leadership to impact staffing of our existing care coordination model across our system of care. So we feel that we can touch and impact more patients if our services are expanded. So that's why we wanted to start with our organizational leadership. And then we felt that we could also go to our commercial and also our Medicaid payers for patients that receive care coordination at CHOC and share our metrics with them, especially with our commercial payers, to see if they would have a special, could get into a contract for a special program with us. So what's the key content of the program that we want to express? So our staff are connecting families to services that could demonstrate a cost savings into tangible cost savings through care coordination interventions. And outcomes like preventing hospitalizations, ED visits, missed appointments, readmissions, and also better quality care for our patients. Also, we felt that improve family satisfaction engagement by facilitating streamlining interactions within the organization. So we have several different teams, but we want teams to be able to own patients. And so we felt that we could for own patients for better patient satisfaction. And so we felt that that could be an enhancement with our team as well. So how will we tell this simply? We could tell it simply by saying that we are an established care management team already. We do have some things that we can work on to improve, especially our metrics that we could share with people. And that some patient populations specifically have funding for care coordination, but for those where populations that we don't, that we could possibly enter into a contract with some of those other payers, and speaking of our commercials. And then what's the story and the quote that, that we want to tell? We want to demonstrate impact of care coordination encounters on a subjective measure of improved outcomes. And then looking at social determinants of health and the impact of health equity for our patients and families. And then positive utilization outcome metrics demonstrated in population health, in populations receiving care coordination can translate into objective cost savings for organizations. So that's where we ended.
Karen, that's great. I think what I'm finding most exciting about what you did is you're not talking to people about basically blowing up the model and hoping for a blue sky. Because I think that you've got an infrastructure, you're going to continue to measure it, you're going to refine it. And so there's something really important about that. And especially since Chalk has already done some publishing in this space. So kudos for talking about incremental. I think Jeff Schiff talked to us about this incremental revolution or transformation. And I think you're absolutely walking that talk. So thank you. Heather, I think we've got 1 minute left, so I don't think we're going to be able to pull in the other two teams. Is that correct?
Yeah, I don't want anyone to feel too rushed, but I think next time we'll be able to maybe start with them, and we'll continue this team report out strategy. I really liked hearing from all of you.
This
and
is
I hope
great.
you guys learn from each other.
So let me grab the last 60 seconds then, and thank you to all of our Academy teams. I want to especially thank Heather and Erica, Meg, Beth, Lynn, and Jessica from BU. Thank our federal funding partners at the Maternal and Child Health Bureau. Anna Marie Padlin is the project officer for the CMC CoIIN. Jeff, as usual, you were absolutely wonderful, and for Foster Geston's guest appearances faculty today. You will be getting the usual email follow-ups from Heather and or Erica around the getting continuing education credits. Number one, we'll be setting office hours for a date in June with Jessica Beliveau to start going into deeper dives on technical assistance for CCMT and PICS. We're going to continue this momentum. We'll look forward to your evaluation for today's session. We hope that it continues to be implement, communicate, and keep pushing this forward. So with that, Heather, I'll hand it back to you to close us out.
All right, thank you everybody so much. Just a reminder, I will email you all later this evening. That will include the attendance link and the evaluation link. It's also been shared in the chat, so if you're able to go ahead and click on the link now, you can complete today's evaluation. Our slides and the recorded lectures, the worksheet template that we've shared at breakout groups will all be uploaded to Open Pediatrics by tomorrow. And in the email I will send you out later, we'll also include the link to Open Pediatrics. If there's anybody new from your team that needs to sign up for an Open Pediatrics account, please have them reach out to me and we'll make sure to get them set up. More to come about the June open office hours. We will be touching base soon. It was so nice to see you guys. I hope everybody has a great afternoon. Thank you.